Okay, right. I'm going to start. Hello there. Thank you so much for joining us today. My name's Teo, and I'm the founder and chairperson for Endo SoS. We raise awareness and provide support for people affected by endometriosis, either directly or indirectly in the south of Scotland and also beyond. We are joined today by one of our medical trustees, Dr Lucy Whitaker, who's going to be talking about endometriosis and pain management, and she'll also touch on the recent the research that's currently happening as well. But before I go any further, I do need to run through some housekeeping with you first. So this session is being recorded, so we would suggest that everyone keeps their cameras off until the Q&A section at the end, where I'm going to then stop the recording so then we can all put our cameras on and we can ask questions. Please mute yourself as well so there's no background noise, and please be respectful of others and remember that this is a confidential space. No individual medical advice can be given. And we do try to be inclusive to all in our sessions, but at points the word women will most likely be said. Please be aware that when we say this, we mean assigned female at birth. We do not mean to offend anyone by saying this. And lastly, please do not name or shame any specific doctors or hospitals, as everyone's experiences are different. So that's literally all I need to say with this. So I'm going to hand you over to the wonderful Dr. Whitaker just now, who you've all really come to see.
Perfect. Oh, thank you so much, Teo, for that really kind of introduction. And I'm very pleased to join you all tonight to talk about endometriosis and particularly about pain management for endometriosis. So I've got some slides, and now I had a bit of an IT disaster yesterday afternoon when I was doing something else with Teo on Zoom. So we'll see if I manage to make it all work this evening. Right. Can I have a thumbs up from someone if you can see my slides? Brilliant. Great. We're off to a good start. So good evening. My name is Lucy Whitaker. I'm a clinical lecturer in obstetrics and gynecology. And what I'm hoping to talk to you tonight is really about sort of endometriosis and its relationship to pain, and particularly pain flares. And we're going to talk broadly about managements for endometriosis-associated pain. And then, as Teo said, I'll finish off by talking about some of the research we're doing here at the University of Edinburgh within Expect, and then finish off with some questions. And again, to sort of echo Teo's comments about inclusivity, I will try and keep, as far as I can, my language to be gender neutral, but for certain studies that particularly we're talking, we do use the word women, reflecting how those who participated identified, but very much acknowledging the importance of inclusivity. So before we kind of launch into endometriosis and talking a little about pain and pain mechanisms, I just wanted to sort of talk a little bit about what I do. So I am a clinical lecturer, so I'm working within the Expect service within the University of Edinburgh and NHS Lothian. So in terms of what Expect is, so Expect is two things. So firstly, it's a clinical care for patients in NHS Lothian, and then for the wider South East Scotland as part of our BSG Centre for Management of Complex Endometriosis. And within that, we also have a specific combined chronic pelvic pain clinic, which was the first multidisciplinary pelvic pain clinic within the whole of Scotland. But Expect just isn't about clinical care. It's also a collaboration with the University of Edinburgh, looking at research into improving treatments for endometriosis and those with chronic pelvic pain. And this is from the real sort of laboratory benchside through to clinical trials to trying to bring about new treatments and better evidence for our existing treatments. So, and now my slides have stopped working. There we go. So in terms of what I do day to day, I'm a senior registrar, and I'm the Advanced Laparoscopy Fellow within Expect. So that's advanced surgery for complex endometriosis. I also have a specific interest in chronic pelvic pain and work with Professor Andrew Horn in our combined chronic pelvic pain clinic. I also have a real interest in menopause as well, and that actually aligns very well with a lot of our work within endometriosis and chronic pelvic pain, both as a consequence of the treatments we sometimes use to manage pelvic pain, which can render people sort of either temporary or permanently menopausal, and also recognising that some of our surgery can then bring on an early menopause. And then with my research hat, so working for the University of Edinburgh, which I do for the other half of my time, along with Professor Andrew Horn, who's another clinical academic, Professor Philippa Saunders, who's a discovery scientist. And my focus is more at sort of what we call translational research. So that's the sort of patient-facing end of the research, so often typically clinical trials. And I work alongside the Edinburgh Clinical Trials Unit, as well as I'm doing some work on epidemiology with the London School of Hygiene and Tropical Medicine. So that's what I do. So 2 hats that I wear. So let's talk here more about endometriosis and particularly endometriosis-associated pain. So there was a survey done by Endometriosis UK not very long ago, I think it was sort of 2 to 3 years ago, and that found that nearly 50% of the UK had never heard of endometriosis, which I still really struggle with because it's such a common condition. So affecting 1 in 10 women and those assigned female at birth of reproductive age in the UK. So that's 1.5 million people in the UK. It's 190 million people worldwide. And it's not just the individual that is affected by this, it's their friends, their families, their loved ones. The impacts of this condition can be absolutely devastating. And now, when we talk about endometriosis, so endometriosis is cells similar to those in the lining of the womb elsewhere in the body. But I think one of the things that's held us back in getting better treatments for endometriosis is that we thought about it as just one single condition. And I think we're now much more aware there's very much 3 distinct subtypes of endometriosis. So we've got what we call peritoneal endometriosis, or sometimes described as superficial peritoneal endometriosis. And that's because it lies on the most superficial layer of the abdominal cavity, which is called the peritoneum. And that's probably the most common subtype. And you see these little lesions sitting here, and they're often only sort of 2 or 3 or 4 millimeters wide, but they can cause really, really devastating, debilitating pain. Other types include endometriosis on the ovary, or endometrioma, sometimes called chocolate cysts. So that's when you've got endometriosis within a cyst on the ovary. And then finally, we've got deep endometriosis. And this is the endometriosis where you've got nodules of endometriosis of more than half a centimetre in size. And quite often they sit on the back of the womb between the uterus and the bowel. You can see here we've got a womb, ovaries, and this is the rectum here. So the back passage that's pulled up because of this big nodule of endometriosis. And we can often see this very clearly on MRI scans. So again, you can see this nodule here of endometriosis on the back of the womb. And endometrioma, we can also see with imaging techniques. So you can see here on ultrasound scan, that's really good for identifying ovarian endometriosis. But sadly for superficial peritoneal endometriosis, because these lesions are really small, they can't be seen on a scan. So neither ultrasound or MRI are particularly good at identifying it. And we don't have a blood test as yet that's reliable for identifying endometriosis, although we're hopeful in the next few years there might be some better tests for it, because at the moment, the only way to diagnose peritoneal endometriosis is to do a laparoscopy, so keyhole surgery to look inside the tummy to allow us to come to that diagnosis. But I think, when we talk about endometriosis, people don't sort of experience their endometriosis saying, "Oh, this is my," they don't come say, "I've got nodule of endometriosis." They come in to us saying, "I've got symptoms," and the kind of hallmark symptoms of endometriosis is pain, particularly pain around the time of the period. But also people can have pain at other times, so not just related to when they're bleeding. They can have pain during intercourse, pain when the bladder's very full or when they're peeing, pain when they're opening their bowels, but also a lot of these sort of more systemic effects. So impact on GI function in terms of constipation, diarrhea, but they're very more systemic, such as fatigue. I think we're now much more aware of quite how debilitating the fatigue that comes with endometriosis. And as well, it's going to have consequences in terms of subfertility. And often a lot of our patients report that they've also got heavy periods or what we call heavy menstrual bleeding. And all of these can then be associated with impact on both mood and be associated with depression, as well as impact on an individual's ability to function on a day-to-day basis, be that from ability to go to work or to function to the best of their ability at work, to every other factor from day-to-day life, as well as impacting on relationships and their families. But I think one of the things we're very aware of is that the subtype of endometriosis that people have and the amount of endometriosis they have doesn't necessarily correlate with their symptoms. And particularly we can find people with very extensive deep endometriosis where there's lots of scarring who might not necessarily have very, very marked symptoms that's impacting on their function and quality of life. And often these are picked up as part of infertility investigations. And equally, you can have someone who's just got 1 or 2 small peritoneal lesions who've got very, very debilitating pain. And I think that's been one of the real challenges for us as clinicians when we're trying to manage people's symptoms, is that we've realized that there is this disconnect between the anatomical disease and the symptoms that people have experienced. And I think One of the old staging systems for endometriosis was something called the SRM staging, when we talk about stage 1, 2, 3, 4. And I think people thought of this as a continuum. But actually, this doesn't correlate to people's symptoms. And I think that's one of the reasons that sort of hampered us in having better treatments for people, because there's been very this sort of focus on the stage of the disease rather than thinking about the subtype of disease, because these probably biologically are very different types of endometriosis, and that's going to impact upon how they respond to your treatments, be they medical treatments or surgical treatments. Because actually, as I've said, people don't come and say, my problem is this bit of my endometriosis. They come in with symptoms, and the main one we see for in the sort of endometriosis service as opposed to the fertility service is pain. And there was some work done in conjunction with Hologic and I think Bodyform a few years ago about a whole load of imagery around pelvic pain. And I think I've always found this image a really, really powerful image of just the awfulness that can be associated with pelvic pain and endometriosis. But when we're talking about pain in a clinical sense, we have this sort of very dry definition, calling it sort of unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in such terms. That's quite a dry definition of pain. But how does endometriosis cause pain? So we've got here a lesion of peritoneal endometriosis. So this is quite a classical, what we call gunpowder lesion. So you can see you've got this sort of whitish scarring, you've got the brown black of the altered endometrium underneath it. You can see all these little blood vessels that have come into it. And it's one of the things about endometriosis, when you have these little lesions on the peritoneum, they cause the growth of new nerve fibers and new blood vessels. That's part of the way in which they survive in these places where we wouldn't expect them normally to be. And all of these processes drives a huge amount of inflammation. So you get recruitments of all sorts of inflammatory cells, and they secrete a lot of chemicals. And these chemicals activate pain sensory nerve fibers, and they send a message up the spinal cord through to the brain, where it's processed initially in the part of the brain called the thalamus, and then onto something called the somatosensory cortex. Now, I promise you, I'm not going to give you a quiz on complex pain physiology later on, but I think it's just quite important to know about these sort of different processing areas of the brain, because it has an implications for some of the treatments that we use when some of our standard treatments haven't worked as well. But we know that these cells that within the endometriosis lesions respond to circulating hormones, particularly estrogen is one of the main drivers of endometriosis, because these cells are similar to the lining of the womb. And so for many people who are not on any form of hormonal treatment, you're going to be having fluctuations in your own normal reproductive hormones. And so at times when your endometrium is breaking down and you're having a period, you're going to get changes in inflammation within these endometriosis lesions as well. So that's why many patients, particularly I think sometimes perhaps earlier in their endometriosis story, their pain might be more significant around the time of their period, although we know many people do go on to develop chronic pain that is present really all of the time. And so there's that, particularly at the time of your period, things being more problematic for many. And I think, but we recognize that many of those with endometriosis will often have quite heavy periods, either because of something to do with the endometriosis themselves and all the inflammation that's going on, but also they may have a condition called adenomyosis, which I always think of as being a bit of a sort of cousin of endometriosis. And adenomyosis is when you've got cells, again, similar to the lining of the womb, but in the muscle layer of the uterus. And again, it can cause periods to be very painful and particularly very heavy. And you can imagine if the womb is having to work really hard to expel large volumes of blood, you've got the uterus contracting to push all that blood out, you've got the cervix having to open up to let blood clots out. All of that is really, really painful and contributes to some of the pain experience of endometriosis. There's also clearly factors that go above and beyond this, contributing to all that pain. I think we're also aware of some of the sort of anatomical variants of endometriosis. So if you've got endometrioma, so that's endometriosis in the ovary, every month when you're going to have inflammation within these cells and bleeding from the lining of the womb, you're also going to get a bit more bleeding into the inside of this endometriosis cyst. And as that cyst gets bigger and bigger, it causes a lot of stretch to the ovary, and it then transmits a pain message. And also you can see here, so here, this is a patient with what we call deep endometriosis. So again, you can see an ovary here, another ovary there. This is the bowel stuck up to the back of the womb here. So all this scarring where everything's really, really stuck together, you can imagine anything that causes movement and tugging on these structures is likely to cause pain. So a common way that this can be moved around is when people are having sex. So that moves the uterus around slightly. So it's going to tug on all this really, really stuck down tissue. And the same way here, if you imagine, you can see that the bowel is really, really stuck in as well. And so if this bowel is having to work harder, so if you've got quite a fluctuant bowel habit, or for whatever reason you've got some constipation, and we'll recognize a lot of the painkillers we use are very constipating. Again, if that's going to have to be pulling because as you know, some hard poo is going through there, again, that's going to contribute to pain. So when we're thinking about pain management in the context of endometriosis, I think we need to be very mindful about, firstly, what subtype of endometriosis are we managing? Because I think we now are much more aware that our treatments need to be a bit more specific to considering the subtype that we're managing. What's the symptoms that that individual is experiencing? And then the pros and the cons and the risks and the benefits of all the treatments that we've got to offer them. And it's helping us and supporting that individual to weigh up of the existing options, which one's going to be the right one for them. And that's what the kind of appropriate treatment for that individual is likely to may well change across their kind of reproductive life, as it were. So, depending on what an individual's wanted to do in terms of pregnancy, is that something that they're actively pursuing at the moment, or have they indeed been trying and struggling to get pregnant and needing fertility assistance? Or is it not something they're pursuing now, but very much is something they want to keep, they want to do in the future? And then at the opposite end of the spectrum, you've got people who have fully completed their family. And that all sort of impacts upon what options are appropriate to offer that individual. And it's about giving them the different options, talking about the pros and cons, and then supporting them to make a decision. And I think one of the challenges that we have is that we know of our existing treatments that we've got, that whilst many of them will help many people, we still don't have all the answers. And also what we're not so good at the moment is necessarily being able to pick the right treatment immediately for the right person. And sometimes it's often a case of trying some different options before we finally arrive on the right one. And I think that's something that we're very conscious that we want to be better about, to be able to identify what's going straight to what will be the right treatment, or the treatment most likely to be effective for an individual, encompassing all these factors of disease subtype, symptoms, and fertility requirements. But broadly speaking, when we talk about endometriosis treatments, so there is surgical treatment, there is medical treatment, and a lot of the medical treatment we use is hormones. And that's because these cells are responsive to the sort of reproductive hormones, particularly estrogen. And so thereby by suppressing estrogen, usually with progesterone, that can help suppress the endometriosis disease. So in terms of surgery to treat endometriosis, so I think we always have to be thinking about an endometriosis. Firstly, what subtype of endometriosis are we treating? Are we aiming just to try and remove the endometriosis itself, or are we removing other structures with it? So particularly, are we removing just the cyst from an ovary, removing the ovary as well for people who've completed their families? Whilst hysterectomy isn't a cure for endometriosis, if there's a lot of scarring and everything's really stuck to the womb, and perhaps the individual either has heavy periods or has got adenomyosis, that group, if they've completed their family, they might have more sustained pain relief if we remove all of that scarring, incorporating the uterus as well. And then we're thinking about how we're going to treat this disease. So are we going to burn it away? So we talk a lot about ablation. Are we going to cut the disease away? That's called excision. And also in some areas that people use CO2 lasers. And I think there's some really interesting work coming through about using very, very high strength ethanol in the insides of ovarian cysts to try and sort of chemically burn away the endometriosis tissue. And equally, this always has to be balanced with the downsides of surgery. So it's, every operation carries risks for general anaesthetic, risks to the structures nearby to where we're operating. So be it bowel, be it bladder, the major blood vessels. And one thing as we as gynecologists are always very anxious about is a structure called the ureter, which is a tube that leads down from the kidneys to the bladder. And those risks of surgeries often differ from person to person, depending on what other medical conditions they've got, what other surgeries they have, what their weight is, which as people's weight goes up, the complexity and the risk of surgery very much goes up. And then also sort of incorporating what their fertility needs are. And I think one of the things that we've struggled with in the past is trying to do the best operation for the right person. So firstly, about reducing risk, getting people for complex surgery, making sure that the surgeons who are doing it have had the appropriate training to be able to do the surgery as effectively, but most importantly, as safely as possible. But also about counselling people about risk of how likely the surgery is to be effective. Because certainly surgery for endometrioma and deep endometriosis do tend to be associated with good outcomes and particularly sustained improvement in pain. And certainly for those with deep endometriosis, the suggestion is about 70% of those undergoing surgery for deep endometriosis will have good improvement in their pain and improvement in their quality of life, but and that's still maintained by 2 years. But for peritoneal endometriosis, we know the evidence doesn't seem to be as strong as that. And certainly if you look at people who've undergone surgery for peritoneal disease, at least half of those will be back with us in gynecology clinics with either persistent or recurrent pain within 5 years. And actually, if you do community surveys and go out and ask people who've been treated with surgically for peritoneal disease, actually that risk of persistent and recurrent pain is probably much higher. And again, I think we've been thinking traditionally of just putting all of these endometriosis types together, but thinking a bit more about specific subtypes of disease. So what about the medical treatments? So as I said, broadly speaking, we use a lot of hormones for managing endometriosis. And this can be from, it's typically progesterone based. That can either be with the progesterone only pill, the Depo-Provera injection, the implants, the Mirena coil. We do also use the combined oral contraceptive because even though that's got estrogen in it, we've also given it with progesterone. So that still seems to suppress down the endometriosis. And I think sort of choosing the right hormone for the right individual, we're very, very conscious that all these hormonal treatments will have differing side effects. And so sometimes there's some been quite useful materials produced by the NICE Institute, so that's the National Institute for Health and Care Excellence, that gives us guidance on what treatment should be offered. But the problem with these hormonal treatments is that we know that they, as well as having side effects, they don't necessarily work for everyone. They're also clearly contraceptive in the main part. And also we know that, they're equally people who, irrespective of sort of side effects or not being effective for everyone, or the fact that their fertility, some people, quite rightly say, look, I just don't want to take any hormones, and that's a very reasonable thing to do. So the other kind of broad elements of our pain medical management include analgesics, and we also use a lot of what we call neuromodulators, so medications that act on the nerve fibers to change the pain processing. So as I said, the hormonal treatments, they are associated with side effects and they're contraceptive, and also when you stop taking them, symptoms tend to reoccur. But they are all equally as effective, so there's not a sort of step ladder of if this one works, this one's more likely to be more effective than others. It's just different ones will suit different people. There are a few newer hormonal treatments that are coming through. So the first one is something called Dynagest. So this is a synthetic progesterone. And this is a hormonal treatment that's been around for actually a really long time. And so in the continent, they've been using this for nearly 15 years, but we've not had it licensed in the UK until last year, which I think something was really frustrating for us. Particularly, we had lots of patients who would move over to the UK from elsewhere, who've been really, really well controlled on Dynagest, and it does seem to be quite a very effective medical treatment, and we weren't able to access it for them. But that has now changed, thankfully, and we can prescribe it, although it's somewhat irritating, it's still not on the Lothian joint formulary. So we're having to ask our GP colleagues very nicely if they will support prescribing this. And then the other group of treatments is called the GnRH receptor antagonists. So alongside our standard hormonal treatments of progesterone-based and the combined oral contraceptive, we occasionally will put people into a medical menopause. And those are with injections called GnRH receptor agonists. And these basically puts you into a reversible medical menopause, which really suppresses down the endometriosis. But the downsides of this drugs is that we're sort of putting people into a menopausal state, which is not very good for your bones and not very good for your heart, as well as all those extremely unpleasant menopausal side effects. And also the way in which the GnRH receptor agonists work is that they essentially overstimulate the ovaries for the first month. So people often got a real flare of their symptoms before their symptoms started to improve. So we've now got a new group of drugs called the receptor antagonists, and these sort of put you in a sort of similar state in that it's a menopausal-ish state. It's not quite as profound as the agonists, but you don't have that initial flare of symptoms in the same way that you have with the agonists. The other good thing about them is that they're also in tablet form rather than a monthly injection. So there's 3 main different receptor antagonists. So I don't know who picked the names because they're really difficult to say. So it's relugolix, elelagolix, and lazanagolix, which I was slightly struggle with. And one of these has got an inbuilt HRT, so it also helps stop people having those menopausal symptoms, as well as giving a bit of brain protection. And there's a lot of really strong evidence to support these the use of these tablets now. And in the new guidelines for Europe, which are called the ESHRA guidelines, which were released last year, these are one of only 8 out of 109 recommendations that's got moderate quality evidence. Everything else is either low or very low quality evidence. So really strong evidence to support their use. A little bit frustratingly, in the UK, they're not yet licensed for endometriosis yet. They are licensed for fibroids. And so I think we will see them licensed fairly soon for endometriosis in the UK, particularly given that the big European guidelines is already recommending their use. But I think it's a couple more months before it will come through. Although I'm aware of some people, particularly within the private sector, because we can access this drug for fibroids, are now prescribing this for endometriosis. But in terms of all our other medical treatments, as I said, so aside from your hormonal treatments, we've got analgesics. And I think it's really important. We know endometriosis is a highly inflammatory condition. So taking a regular non-steroidal anti-inflammatory, I think, is extremely important as part of the pain management. Though I appreciate that not all people can take non-steroidals, so things like ibuprofen, diclofenac. But I think they are sort of my go-to painkiller. And then paracetamol works in a different way. And again, it's a really important that it isn't a good painkiller. It may not necessarily control all of people's symptoms, but having those two in combination, then adding extra things on top of it, I think is really important. I think opiates, so stronger painkillers, they're sort of a bit of a double-edged sword with endometriosis. I mean, opiates, if you break your leg, are great. They're really effective painkiller for acute pain. In terms of management of a long-term chronic pain condition, we know there's a lot of downsides of using opiates. So firstly, they become less effective over time. They have a lot of side effects. And one of the sort of real side effects that I find very problematic in the management of endometriosis is that they're hugely constipating. And for reasons that we'll come on to later, anything that makes your bowel more sluggish is often a bit sort of counterproductive in the management of endometriosis-associated pain. And they are also quite addictive, and they also start to change how the brain processes pain messages in a negative fashion. And then they can also be quite sedating and have an impact on mood. So one of the things we try and do, particularly in the complex pelvic pain clinic, is try and reduce people's use of opiates, particularly on a sort of daily basis. I think if people have sort of identifiable flares, then there's more of a role for kind of, a brief flare management to sometimes have an opiate as part of that. But by and large, we try and get people onto other treatments to give them effective control of their symptoms without them needing to use opiates. And one of the things we use a lot of is neuromodulators. So these are medications that act on the nerve fibers of endometriosis. And I think also the other thing we recognize that if our kind of standard hormonal and surgical treatments aren't working, we need to have a slightly more multidisciplinary approach to pain management. So that's as well as also myself as a gynecologist, working alongside pain physicians. Our physiotherapist, I think, sometimes is the most useful person in our pelvic pain clinic, but also the support of our nurse specialists and our psychologists. And I'll come on sort of what their different roles are for the management of symptoms. But before I'm going to take you through this slightly difficult slide. As I did promise I wasn't going to do lots of pain physiology, but I did want to try and take you through this because I think it's a really important concept to get your heads around in terms of why having this kind of multi-pronged approach to pain management is really important, particularly when the pains become more complicated and chronic, to be able to sort of give people quality of life and function back. So as I said, endometriosis is hugely inflammatory. So you've got lots and lots of different pain signaling molecules being released by the endometriosis lesions. And as well as transmitting a pain message, those pain signals, and there's something about the inflammation of endometriosis particularly, that cause the recruitment of a whole load of new little nerve fibers. So you have not just got all the existing sensory nerve fibers, but you've got lots and lots of extra ones, which seems particularly unfair when you're already in a painful environment to then have even more extra nerve fibers who are all going to be told pain is happening, damage and danger is being done. And we know over time that these, both the original nerve fibers and these new nerve fibers, all become very, very overly sensitive and irritated. And that's something called peripheral sensitization. And that means that people start to sort of experience things that shouldn't be painful as a painful stimulus. So I have people who come to my clinic who I, put bits of cotton wool across their tummy and they feel that uncomfortable. And we see that people reflecting going, oh, well, when I wear certain types of clothing or, perhaps particularly sort of tighter underwear, that actually caused me quite a lot of discomfort. And that's all signs that those nerve fibers are not transmitting pain messages normally. And with this sort of peripheral sensitization is really, really important. And I think it's a lot of the reason that why, even when we've done a laparoscopy where we're very confident we've removed absolutely all of the endometriosis, because we can't take away these irritated nerve fibers, people still continue to experience pain. And over time, when you keep on getting these irritated messages going up the spinal cord to the brain starts to change in how it processes pain messages, and this is something called central sensitization. And once this starts to take place, it then becomes much, much harder to try and reverse all these sensory changes. And this central sensitization is impacted not just by all those sort of pain stimulus messages you're getting from the nerve fibers coming up, but there are other factors that also impact upon how your brain processes pain. And that includes sort of psychological, behavioral, and social factors, sleep quality, depression. And I think the whole relationship between mood and endometriosis is really complicated. And there's no doubt if people have got really debilitating pain, that's a miserable thing to have to experience. And if you start having to alter your day-to-day activities, that can then lead to sort of further changes in mood, withdrawal, isolation. But sometimes it's a bit more of a sort of chicken and the egg type thing, because a hormone that's very important is mood is something called serotonin. And this hormone is also really, really important in pain processing. And so if someone, for whatever reason, has less of this hormone serotonin in their brain, that's going to cause them to have low mood, but it's also going to impact upon how their body processes pain. So they're going to experience things that shouldn't ordinarily be particularly painful as a much more painful stimulus. And so that's why this sort of interplay between mood and chronic pain is a complicated thing. And I think one of the things that sort of held us back is all the stigma around mood and also the stigma around chronic pain conditions. But it's why it's really important to address the mood and depression component of patients who present with pain. And then finally, I want to talk to you about this little concept of cross-sensitization. So we don't just have one nerve fiber for each bit of our body. You have the nerve fibers going to the endometriosis, going to the spinal cord here. And then you've got other nerve fibers that are also going to the bowel, to the bladder, to the womb, as well as a lot of the sort of muscles and the fibrous layers that overlie new muscles, which are called fascia. And they all then get looped in sort of, fewer nerve fibers. So you've got in a nerve fiber in your spinal cord, it will have messages coming from your endometriosis, but it'll also have messages going from your bowel. And over time, because this nerve fiber here going to the endometriosis becomes so wound up, that starts to send a backwards message to the bowel and to the bladder and to all these other little sensory nerve fibers that they start to become overexcitable as well. So even though there's no inflammation or irritation within the bowel itself, it starts to send messages saying, and that becomes more irritated. And that's why there's a lot of crossover between endometriosis and irritable bowel syndrome. And I think historically that was a really difficult thing to explain to patients, partly because with all the issues with diagnostics around endometriosis, a lot of people were not escalated to gynecology, offered laparoscopy to look for their endometriosis because they said, oh, you've got irritable bowel syndrome. But the reality is a lot of those people had irritable bowel syndrome because they had endometriosis, and it's this cross-sensitization. And certainly we know people with endometriosis are 3 times more likely than the general population to have IBS because of this crossover. And the same way that we see high rates of something called painful bladder syndrome or interstitial cystitis, which is basically the IBS of the bladder, again, with people with endometriosis, and, much more likely to sort of have heavier painful periods, and their uterus becoming much more people experiencing pain even when the bleeding hasn't necessarily increased. And then we see a lot of myofascial pain. And some of that is because the nerve fibers going to the muscles have become more irritated. Some of it is also because if you are sore, you hold yourself in funny positions. Same way if you've got a headache or a migraine, you sort of hunch your shoulders, and then you start to get lots of tension points within your shoulders. So the same things within your pelvis. If you've got pain, you'll start sitting in funny positions, you'll start tensing your pelvic floor, and over time you start to develop all these sort of trigger points within the muscles. And then it becomes this vicious cycle that those trigger points themselves start to contribute and cause pain themselves. So it really is a sort of completely grim, vicious cycle. But it's why just removing the endometriosis sometimes isn't necessarily all that effective about improving the pain, because you've got to address all these other features as well. So this sort of leads into some of the other strategies that we use for pain management. So if we're talking about this peripheral sensitization and the central sensitization, we need medications that act on the nerve fibers. And there are lots of different medications out there that a lot of them were originally designed for completely different conditions, but we found that they do have this action on the nerve fibers, and that's rendered them really useful for use in this what we call neuropathic pain. So this is the pain coming from the nerve fibers not functioning normally. And one group use is a group of drugs that historically got used as antidepressants that are actually really not very effective antidepressants, but they're really good neuropathic pain medications. And that's typically things like amitriptyline, imipramine, and nortriptyline. Downsides to these drugs, they've got quite a lot of side effects, so particularly a lot of dry mouth, and slightly can impact upon the bladder. The key one, and I think the one that's used very often, is amitriptyline, because a lot of people are having poor quality sleep, and it can help people with sleep. But I find it's really associated with sort of almost a hangover type feature in the morning. And we know with these drugs, we need to get them up to a reasonable dose. And often the side effects people get, particularly from amitriptyline, means that we can't get them to a high enough dose to be effective on the nerve things. And all of endometriosis pain management, it's all about quality of life. And if you help someone's pain, but you give them terrible side effects from that drug, then you're no further forward. It has to be about balancing effectiveness of the drug with side effects. Another group we use is something called the gabapentinoids. That's gabapentin and pregabalin. They're originally used for epilepsy. And then also some drugs called duloxetine and fluoxetine. So again, duloxetine, it's a third-line antidepressant. There are better antidepressants out there. And we're not doing this because we're saying people are depressed. We're working on this sort of peripheral sensitization. Now, some people might have low mood as well. And as we've talked about, sort of that role of serotonin. So sometimes they've got kind of the added benefit of helping support mood as well. But really, we're using them primarily for this effect on nerve function. And then when we're thinking about our cross-sensitization, so if people have got a lot of IBS component to their pain, there can be specific medical treatments that we can give people. But I'm a big fan of giving people strategies where they can self-care. And I think particularly giving them some control over their symptoms. And I think diet is really interesting in the management of pelvic pain. And now, there isn't, unfortunately, a sort of single specific endometriosis diet that works well for everyone. But for different people, if they've got a sort of strong IBS component to their symptoms, then doing some dietary modification can help. And now, for some people, that trigger is gluten. For others, it's lactose. Some people, it's sugar. Other people, it's alcohol. Others doing things like a sort of low FODMAP diet. So that's sort of cutting out, there's an element of gluten and lactose from that, but also sort of vegetables and things from the nightshade family, so onions and garlic. What I would say is that dietary modification always has to be done in a considered way. And I'm not a fan of really big restrictive diets, and not least because that actually means that you'll end up not getting the right nutrients. But I think it's worthwhile keeping a food diary, trying to see what your individual triggers are, and then try cutting them out for sort of 3-4 weeks, seeing if that helps. And if not, add them back in. And then for some individuals, we know even when you've identified a clear trigger, you might say, look, say for one person, it's strawberries. And they go, I know if I have strawberries, I'm going to have a pain flare. But they might go, you know what, I really love strawberries. And maybe once a year, I'm going to have those strawberries because I love them. And I know I'll pay for it in a couple of days' time. I think this all has to be balanced. It's about, having joy in your life. I think the other thing we're really interested in is the gut microbiome. So that balance of bacteria in your gut, and, lots of talk about good bacteria and bad bacteria. And that definitely has an impact on inflammation in your body, of which, fits with endometriosis being hugely inflammatory. But also we're trying to work out if we can change that microbiome. So your gut bacteria, could that help with people's symptoms? And I think there's a lot of interest, particularly in sort of fermented foods. So you'll see kombucha and kimchi and all of that. And, I think, in 10 years' time, I think we're going to be doing a lot more dietary modification to try and help people with symptoms. For those who've got a lot of painful interstitial cystitis and painful bladder syndrome, sometimes doing installations can help. And that's something that's managed by our urological colleagues. For people who've got heavy periods, that is going to contribute to people's pain. So sometimes our treatments are also targeted around, reducing the volume of blood that's coming out of someone's uterus. But again, I think this has to be balanced between what their sort of current fertility and contraceptive needs are. And then we talked about the myofascial problems, and our physiotherapist has been a huge part of our pelvic pain service. I think also it's why that certainly there is some evidence that things like yoga and particularly Pilates can help with endometriosis pain. And I think that's because that helps with sort of all that core strength. And also there's something about that sort of the low impact stretching that can sometimes help iron out some of the trigger points. But certainly physiotherapy can be hugely helpful. And there's physiotherapy that can be accessed through your community and through your GP. I mean, I think, as with many things in the NHS, the waiting time, the demand for it is absolutely terrible. But that can be a really helpful resource. And particularly for patients who are having a lot of pain with sex, helping some physiotherapy, particularly on the pelvic floor, can be really, really helpful. And then finally, this is the importance of psychological support, both about sort of empowering people, understanding about their triggers, but also giving them structures to help manage their symptoms, their day-to-day life and their function, and particularly overcome the isolation. One of the things we get asked about a lot is complementary treatments. And again, kind of on that dietary theme, there's a lot of really nice preclinical evidence. So from sort of laboratory models about things like omega-3 and turmeric. I think we don't have the big clinical trials to say whether or not these things are effective yet, but it's certainly very much sort of active line of scientific research at the moment. Acupuncture, there is some evidence to support acupuncture, and that can be helpful. Again, in terms of Chinese traditional medicine, the evidence base is a bit more muted out there. And then I've put up a cannabis picture here. Now, I'm not suggesting that people go and smoke cannabis. Please don't think I'm saying that. Particularly, I have real anxieties of women of reproductive age smoking cannabis when we know it's incredibly harmful in pregnancy. But I think some of the individual chemicals within cannabis are really interesting as potential for endometriosis-associated pain. And we know a lot of our patients report benefit from using cannabinoids, so those chemicals from a cannabis plant. And there's a lot of preclinical works, again, laboratory models that suggest these all might be quite interesting in how they might alter inflammation associated with endometriosis pain signaling. And this is very much sort of area of active research at the moment. And I mentioned a little bit about self-care. We talked about dietary modifications. I think the other thing that I find a lot of people, if they're having a lot of bloating, sometimes peppermint tea can be quite helpful. Low impact exercise, again, sort of Pilates, improving core strength, that can be helpful. I think it's also about taking time for yourself, which is hugely important. In terms of topical treatments, heat, always remember, don't put a hot water bottle directly on your skin, but sort of heat packs can be really useful. And one of, I think, things is really helpful, particularly if there's a lot of musculoskeletal component, is a TENS machine. And you can buy these over the counter in places like Boots, and they're much more discreet than they used to be. And I think those can be really helpful managing, particularly when sort of having pain flares. And then I think also there's this importance of pacing, and women are copers. I think if men had to go through what we experience, we'd probably have got to a cure for endometriosis much earlier than we have done, because they just wouldn't accept what we put up with. But I think there is also this phenomenon that when people are having good days, they go, right, I'm having a good day, I must get everything done. And then actually you do too much, and then you completely fall off your perch, and then you've got to get a pain flare. And so this idea of sort of not doing the boom and bust, pacing things a little bit more often, and that actually then allowing you more predictably to try and achieve what you would like to do. And I think also as part of that, being kind for yourself, taking time for yourself, that sort of mindfulness, and also to strategies for when you are having a pain flare, to distraction therapies. And that can be, those will be different things, will suit different people, about what you can use to try and take yourself after your pain flare, to be able to cope with it, to get, and then as your symptoms get better, with some of the other strategies we've talked about, but just to give you more control over your symptoms. I think the importance of self-care and self-management was really, really, I mean, something we've always needed, but was really highlighted during the COVID pandemic, when people couldn't access what we were sort of traditionally offer for endometriosis pain within the NHS. And there's this really nice study that was written, partly from our research in Edinburgh, but from other researchers in endometriosis across the world, about self-management strategies and some of the evidence based to support all of that. So I know this is a scientific paper, but it's really well written, and you might find that interesting to look at. And finally, I know I've talked a lot, but I did promise Teo I would just do a little bit of talking about some of the current research we're doing at Expect, because we absolutely recognise that our existing treatments, whilst they will work for many, they absolutely don't work for everyone. And we need better treatments. We need ideally non-hormonal medical treatments to be able to offer patients a variety of options for whatever the right one is for them at whatever time of point in their life. And with the work we do here in Expect, we do quite a lot of trying to understand endometriosis, and that has then led to some of the new treatment targets we're now actively exploring. But some of the sort of discovery studies we run a big tissue resource collection called EduMed. We're part of something called the ADHP Alleviate Pain platform, and particularly a study called Advantage. And this is looking to try and understand sort of genetics and changes in people's pain processing and how that contributes to endometriosis-associated pain. We're very aware of the link between fatigue and endometriosis. So we're running this big survey at the moment called, I think it's called Endo Fatigue. And we're doing a study called Endotech, which is looking at smartwatches, trying to explore that relationship between activity, sleep quality, and pain flares. That's getting people to wear smartwatches. And as I've said, we're really interested in the gut, and particularly the gut microbiome, so that balance of bacteria. So we're doing a study where we're taking lots of people's poo samples and looking at the changes in their bacteria within and how that relates to their symptoms. But the other bit we do is we do big clinical trials, and it's quite an exciting time in endometriosis research across the UK, because the main sort of governmental funder for research has funded 3 really big surgical trials for endometriosis. One is the one that we're leading from Edinburgh, which is called Esprit 2, which is trying to work out better who surgery for peritoneal endometriosis is benefit for and who it isn't. Because our existing evidence that supports us using surgery to treat peritoneal endometriosis, that's based on 3 studies of only 171 patients, and only one of those studies followed up patients beyond 6 months. And it also included patients with deep and ovarian endometriosis. So it's a really poor evidence base to counsel patients on. And we know that there is very high rates of recurrence and persistent pain after surgery for that type of endometriosis. Regal is looking about what to do with patients who come back with pain after surgery and trying to work out what the best way to manage those patients are. And then Diamond is a study looking at specifically the management of deep endometriosis and trying to work out for whether or not for patients is medical treatment or surgical treatment, what makes people happier. And it's balancing that sort of risks of surgery versus medical treatments. But 2 of the studies that we've got coming up in Edinburgh, which have been recently funded, One of them is Endocan. So I talked a little bit about cannabinoids. So this is looking at a CBD tincture. So the Scottish Government has funded a cannabinoid study. And so that's a feasibility study that we're going to be starting next year. But the study I'm really excited about at the moment is something called EPIC2, which has been funded by the Scottish Government as part of the Women's Health Plan, as well as Wellbeing of Women, which is a women's health charity. And this is really kind of building on 10 years worth of work within Edinburgh. So as part of our tissue resource, we took lots of samples from people with endometriosis and who didn't have endometriosis at the time of surgery. And that allowed us to identify that there was a lot more lactate in the pelvises of people who had endometriosis. So lactate, a substance produced when the cells don't have as much oxygen. And that is a potential new treatment target. So rather than kind of acting on the hormone pathways, it's a non-hormonal target. And there are drugs around that can be used to reduce the levels of lactate. So one of these drugs is called something called dichloroacetate, which is a drug that's been around for about for decades, really. And we use it to treat children with metabolic disorders, so children who have really high levels of lactate. And it's also been used in quite a lot of trials for sort of cancer treatment, because this similarity in changes in lactate levels is something we see in cancer as well as in endometriosis. And certainly in our laboratory models of endometriosis, we found that if we gave dichloroacetate, or DCA is its sort of short name, that reduced the levels of lactate, and the cells didn't seem to grow as much. And then we've also done some work in mice who we gave endometriosis to, and the dichloroacetate was really effective at shrinking down their endometriosis lesions. And then we did this small study just over the time of COVID, terrible time to do a clinical trial. But that was just in 30 women, and they all got the dichloroacetate for 12 weeks. And you might have seen some of the press that was around that. Now, this is a tiny study. They all knew they were getting the drug. And the study was really just to see if people were willing to take part in a study where they got given dichloroacetate. And like any treatment, it didn't work for absolutely everyone. But for a lot of the participants in this trial, it was really exciting, the improvement they had in their symptoms. And so that's led us on now to EPIC2. So we're now in that study, there was only 30 women. This is going to be a study of 125 women, and half of them are going to get DCA and half of them are going to get a dummy tablet. And the aim of this study is really to determine firstly, make sure we've got the best dose of the drug, particularly balancing that impact on pain symptoms against minimizing side effects. And also really to make sure that we've got the right study design. So we're going to run this in 2 sites, so NHS Lothian and the Chelsea and Westminster Foundation Trust in London. We're going to start recruiting from October 2023. And this is recruiting people who are 16 years and older with peritoneal endometriosis. And the reason we're just recruiting peritoneal endometriosis is that's what all the laboratory data supports. And those who are not actively seeking to conceive, and they'll take the drug for 12 weeks. And then we'll see what happens to all their symptoms and their quality of life and things like that, factors such as sexual function. So I'm really, really excited about the trial. This isn't going to be the definitive trial. We're not going to know at the end of this, does it definitely work or not, because we need a much bigger trial, so probably with around about 400 women across the UK. But it's really important to make sure we've got absolutely the right trial design before we go on to do that much larger trial. So I'm really excited about this. So I realise I have talked for quite a long time, but in terms of pain relief for endometriosis, I think one of the important things is a positive that for many people, hormonal treatments or surgical treatments will be effective, but equally we will know there are many that they're not effective, and there isn't sadly a kind of one size fits all or one drug that works for everyone. And also that an individual's needs will change over time, and different things that worked well and were appropriate from that one point in their life may not be appropriate for later on in their life. And I think particularly when our kind of standard first-line treatments aren't working, it's really important to have a multidisciplinary approach. And as I said, our physiotherapist, I think, is the most popular person in our pelvic pain clinic. But I think it's also balancing other forms of management, including sort of neuromodulators, dietary modification, etc., but also sort of empowering you with self-pressure strategies to give you some strategies that you can deploy, particularly when people are having pain flares, to try and help them get through those flares. and really the aim is to give people back some control, give them back their ability to function and improve quality of life, and allow them to do what they want to do on a daily basis. And I think, as part of, when the pain becomes very, very complicated, we know that we aren't necessarily going to be able to make someone completely pain-free, but we can make their symptoms much better, and we can allow them to do what they want to do. And I think that is the most important thing. And I suppose also I hope that in the next few years, with all the work that's been done, across the UK, across the world, we're all working together much more closely and much more aware of what we call precision treatment. So trying to get the right treatment for the right person based on their symptoms, based on their subtype of disease, based on their genetics, so that we can try and give people better treatments, better control of their symptoms. And I still really hope that we will have an actual cure for endometriosis one day, and we can do more, because it's an awful condition with such an impact on people's every facet of their life. So I just want to finish up with thank you. This is